Can you see my screen also, Rakesh?
Yes, George.
Okay, good morning, everyone. Mahi, thank you for the invitation. I'm Dr. Christodoulides. Today I will be speaking about mitral.
There's a little beeping sound in your background, I think. I don't know if you have a second device or something behind.
I'm not sure, actually. Probably from the air conditioning of the office, actually, I would guess.
Then go ahead, that's fine.
All right. So I have no conflict of interest. So going along, every talk about mitral valve should probably start with anatomy. As you all know, it's a complex three-dimensional structure comprising of 5 distinct but highly integrated levels, which are essentially the leaflets, the commissures, and the annulus. And then you have the subvalvular apparatus, which basically is compromised by the aorta and the papillary muscles. Now, you do need to remember, of course, that the LV is, of course, not a part of the mitral valve, but it does have an integral role in the mitral valve function. So this is a nice schematic of the mitral valve, which basically essentially shows the basic things that I just mentioned. You can actually see here, we have the mitral annulus, the anterior mitral annulus, the posterior mitral annulus, the anterior leaflet and the posterior leaflet. You can actually see that the posterior leaflet actually takes more of the perimeter of the mitral valve, and then you can see that the anterior actually gets less of it, but it's actually a longer one, so the overall surface area is about the same. You can see them in different scallops. You can see the commissures where the two leaflets meet. And then, of course, you can see the subvalvular apparatus, which is compromised by the aorta tendini and the two papillary muscles, the anterolateral and the posteromedial. It's worth to remember that both the papillary muscles, they provide the aorta to both the anterior and the posterior mitral leaflets. And of course, you can see how important would be the LV in the function of the mitral valve with the close association here. I will talk about that later on. This is a completely normal echocardiogram that is depicting the mitral valve in the parasternal long axis. I'm sure you've seen it a ton of times, but the reason I'm showing you this one is kind of like to compare and contrast with the subsequent abnormal that I'm going to be showing you. So here you can see actually the anterior leaflet that is nice and crisp. There is no calcifications. It's opening and closing without any problems. And then you see the posterior leaflet. And then you can also see that the LV looks perfectly fine. There is no issues here, right? And then you can see it also in the fourth chamber, again, anterior and posterior leaflet. Just putting your head in kind of comparison with what you are going to be showing down the road. Moving along, epidemiology. As you guys know, trivial amount of MR is very common. Probably more than 70% of patients do have it, and it's completely healthy, and there's nothing about it. Mild MR is a little bit less common, about 20% of the population. And then most important for our conversation, the moderate or severe MR, about 2% the moderate, 0.2% the severe MR. You would probably think that, you know, when I'm reading on the echo lab, I'm seeing much more than that. Well, that's probably selection bias. You're in the hospital, you're seeing more sick patients, obviously. You don't see the ones that they have nothing, right? Now, moving along to the etiology. So we're going to drill that again during this presentation, but there is two completely different entities. There is the primary MR, which is essentially a structural degeneration of the mitral valve apparatus, and basically the problem is on the mitral valve. Whereas the secondary mitral disease, mitral valve regurgitation, and the mitral leaflets are completely fine, and it's actually a disease of the left ventricle. What is exceptionally important to remember is that basically those two, even though they are both causing mitral regurgitation, they are both completely different disease. They differ in their pathophysiology and their prognosis and in their management. So for every intents and purposes, you should clearly differentiate between the two of them and manage them accordingly. And we're going to talk about that later on. Moving along to primary mitral regurgitation. As we said, primary mitral regurgitation it's a valve pathology. What is the most common cause? The most common cause is the myxomatous degeneration of the valve. And this basically includes a spectrum of disease, starting from Barlow disease, which is a diffuse thickening and redundancy of the leaflets, typically affecting both leaflets and multiple scallops. And actually it does affect the corti also. And it's most commonly seen in, or at least most commonly diagnosed early in life in primarily younger population. On the other side of the spectrum, there's the fibroelastic deficiency, which is a more focal segmental pathology, with the otherwise the leaflets being nice and thin. And it's primarily diagnosed in older people. And that is actually a picture from the guidelines, which is showing you a 3D of the mitral valve. And you can see on the left of the screen how a normal 3D should look, A1, A2, A3, P1, P2, P3. Nothing abnormal here. In the middle, you see going to the spectrum of the disease, you see the fibroelastic deficiency. You see there is a problem here at the P2 level, maybe a little bit on the A2. And then you come on the Barlow's disease that pretty much everything is thickened and redundant and probably prolapsing also. Moving along, when in a Barlow disease, what is the problem? So basically you have thickened redundant leaflets which are going to prolapse back into the left atrium. And by definition, prolapse is more than 2 millimeters below the level of the annulus. You're going to have malcoaptation of the leaflet edges, and then you are going to have subsequent regurgitation, right? Remember when I showed you the initial normal leaflets that they were actually nicely collapsing at the level way above the annulus. So now look at this one here. So this is not subtle, right? You have thick leaflets, right? Actually, let's start from the beginning. The LV looks fine, right? Nicely contracted. Now going to the leaflets, they are thickened and they are prolapsing. And there's actually bi-leaflet prolapse in this case, right? Both the anterior and the posterior are actually coming way below the annulus, right? Now, this situation can remain for years, and you're going to have a patient with maybe like moderate mitral regurgitation that you keep following. However, people with this type of disease, the Barlow disease, as I mentioned before, they have problems in the cords also. So it's not uncommon to have a spontaneous rupture of the chordal structure. And that, if that happens, then you're going to have significant increase in the severity of your mitral regurgitation. Like in this case here, again, this is not subtle. What is the problem here? So obviously you do see that there is a thickened valve. You do see that there is prolapse, but more than just the prolapse, right now, what you are seeing that the tip of the posterior mitral leaflet is actually pointing towards the left atrium. This is like the hallmark of a flail leaflet, right? And you can even see a small gap here between the anterior and posterior leaflet. Now, once you see that, even before putting in color, you should know that you should expecting quite significant degree of mitral regurgitation. And you should be predicting actually that your regurgitation should be anteriorly directed. And sure enough, when you put the color here, you can see this big jet anteriorly directed, very eccentric, right? As we kind of predicted. This is actually a still frame of a T, and I'm showing that just to kind of reiterate the hallmark of a flail leaflet, which is basically the tip of the leaflet pointing towards the LA. Then you put the color, you see all this regurgitation here, and then you have the pathologic anatomy here, and you can see exactly what is the problem here, right? There was a cord rupture, right? You see, guys see that here? So this is exactly what was the problem. Now, some other causes, definitely not as common. Rheumatic disease, it's not uncommon. Essentially, every case that I have seen is always with concomitant mitral stenosis, though. And as you do know, if there is significant mitral regurgitation, it's one of the contraindications to be doing balloon valvuloplasty. So it's important to identify. Very rare causes, the drug-induced from ergotamine or bromocriptine. I've never seen one case, I have to be honest here. Radiation heart disease, this is not uncommon actually, especially with the older ways that they used to treat Hodgkin's lymphoma, or even now with breast CA. Radiation heart disease is not uncommon. As you guys know, that does affect the aortomitral continuity, and it can cause problems, both stenosis and regurgitation. Infective endocarditis, unfortunately, is quite common. We've seen a lot of cases here. And then finally, some rare cases like congenital malformations, including the cleft valve. You'll probably rarely gonna see those type of things. Pathophysiology of the disease. So this is essentially a volume overload of the LV, very relevant for your bones actually. What you end up happening, you have compensatory increasing the myocyte mass to normalize for the wall stress. As you know, the thickness is actually inversely related to the wall stress. So what end up happening is that as the LV changes, compensatory change, you are actually entering a chronic stage of asymptomatic mitral regurgitation, which can be quite long-standing actually. However, at some point, you're going to have progressive LV enlargement, strengthening of the myocytes beyond their normal contractile length, right? You guys all remember about your Frank-Starling curve. This basically is going to lead to interstitial fibrosis and is going to lead to subsequent decrease in the contractility, right? And then finally, this is going to increase your LV diastolic pressures, your left atrial pressures, and then you're going to start having symptoms. What symptoms are you going to have? Obviously, you're going to have the primary symptom is actually exertional dyspnea due to the high LV-LA pressures. Down the road, as disease gets more prominent, you're going to start having fatigue because of the decreased forward flow. Hopefully, you're not going to let your patient to get there, of course. Atrial fibrillation is very common, of course, because of the atrial dilatation. And you have to be very careful because if you leave this patient untreated, once they get into the decompensated phase and you leave them untreated, then you're actually going to have, it's going to be at one point that is going to be an irreversible LV dysfunction, even when you fix the mitral valve. You don't want that to happen to your patient, of course, right? Moving along, how are you going to diagnose it? Echocardiography is by far the most important modality here, both TT and TE, both 3D and 2D, of course. Cardiac MRI actually has an important role, especially if you are having difficulties with quantitation with your echo. And then there is some limited role in stress testing and cardiac catheterization. I'm going to touch on that later on. Moving along, echo, as I said, is probably the most important here. What is echo going to give you? Obviously, as I kind of briefly touched before, it's going to give you the anatomical features of the valve. You have to pay specific attention for the presence of thickening or calcification of the valve. Is there any signs of prolapse? And if there is any signs of retraction of the leaflets? And of course, that's going to give you a very important insights regarding to the mechanism of the MR. Of equal importance, though, is going to be the LV, right? So you have to pay attention on the size, function, and dimension of the LV. It's extremely important, both for the mechanisms of the MR, but also as indications for surgery. Dimension of the left atrium is also important. I will touch on that later on with that newer entity of the atrial MR. And then other important things is the presence of concomitant pulmonary hypertension, because that might be an indication for surgery, as we'll speak later on. And of course, there is the quantitation of the MR that we are going to briefly speak about later on. Moving along, if you are trying to identify the mechanism of the MR, probably a T would be needed, right? So this diagram is actually from the guidelines, the ACC guidelines of how should you evaluate mitral regurgitation. And then you basically should get at least 4 different angles, 0, 45, 90, and 135 degrees. And I know that is the pain of the existence of every cardiology fellow, trying to figure out what are the scallops of that you see in each TE view, right? And let me tell you that is not easy. And then more than that, in order to identify scallops, you have to recreate the exact images that you have here. So if you are a little bit higher, if your probe is a little bit higher, if your probe is a little bit more rotated, even though it's a 4-chamber, for example, if you are not recreating the view that is cutting through here, right, you are not going to have these scallops, right? Because the whole idea is that what you are doing is that you're seeing the A2 because you are cutting through here, and you go A2, A3, A2, and then you go to P2 and P1, right? However, if you are a little bit more angulated, if you are a little bit more rotated, you might be completely misleading, right? 45 degrees is usually a little bit easier because you create that trap door. And then remember that the posterior leaflet has more of the perimeter of the annulus. So what happens is that when you're cutting through the commissures, you're basically seeing P1 and P3 on the edges here. And then in the middle, the trapdoor, as we call it, is going to be your A1, A2, A3. Moving along to your 19 degrees, that's again a little bit easier as long as you recreate this view here, is A1, A2, A3, and then you're going to have P3 right here. And then finally, again, pretty easy, this one also in your 135 degrees, the favorite views of the structural interventionalists, where that's the view that they use mostly actually for their mitral clips. You're actually doing you're cutting through the A2 and the P2. So generally what I would say, these three are relatively easy to recreate. The fourth chamber can be tricky sometimes. Now, fortunately, newer technology, not exactly newer, it's been here for quite a bit. The 3D makes things much easier for us and much easier for the surgeons and the interventional cardiologists. So what you do, you do your 3D zoom, you put your aortic valve kind of on the top here, and then you clearly have your anterior leaflet, posterior leaflet, A1, A2, A3, P1, P2, P3. This is really nice, very easy, and it's actually very easy to show to your surgeons which are not that expert in echocardiography, of course, right? So especially if you are considering surgery 3D, I think it's a must to be done during your study. And this is actually kind of an example of what we just said. So you have here your 135 degree. You can see that there is a flail leaflet here, right? If you were to guess here, again, you don't do it just by one screen, but you're thinking that it's probably a P2, right? As we said, this is A2 and P2. You put the color that's clearly severe MR. Then you did your 3D, and that's pretty much showing what we said before. You have the flail leaflet, you have even parts of the cord here, and then they did their surgery, and you can see what the problem was as we completely predicted based on our echo. Moving along, quantization of the MR. As you guys probably know already, this is actually something that is a lecture by itself, very relevant to anyone that is considering to take the echo boards that I know that they're upcoming on September. I'm going to touch a little bit and give you some my approach, but of course we're not going to go in detail. So it should be a stepwise approach, right? Again, start with your 2D imaging. We beat that to death, but you have to pay attention. Both start with your LV, make sure that your LV is normal, or if it's abnormal, kind of thing, what is the problem? Then go to your leaflets, see if they are thickened, if there is tethering, there is prolapse, all those kind of things. And in your mind, actually do the mental exercise that before you even see the color of the mitral regurgitation, try to predict what is going to be the problem. Because if you start consistently predicting what is going to be the problem, that means that you are actually mastering what you are trying to do. Obviously, you move along to your color Doppler. That's very important. Obviously, if there is a large color Doppler going into the left atrium, usually more than 40–50% of the ALA, kind of suggests of severe MR. You do your PW, including the PW at the level of the pulmonary veins. You want to see if there is any systolic flow reversal. Remember that systolic flow reversal to denote severe MR should be more than just one pulmonary vein. So you should at least show two. Move along to your CW Doppler. Remember that if you have like a triangular and dense signal that's suggesting more severe disease. And then finally, whenever you are thinking anything more than mild to moderate disease, you should be doing some kind of quantization. We routinely do PISA here. I have been trying to do continuity ever since my fellowship, actually. I'm going to say that is with the various degrees of success. Sometimes it comes right to the point and it makes sense with everything else that I have done. Sometimes it gives me something completely different. I do have to tell you, you definitely have to know it for your boards. You definitely, and keep in mind that the guidelines written by Dr. Zogby, he's very convinced that it's a useful thing to use. What I would recommend to you, if you want to be doing continuity equation, you should start doing it in normal good echoes. Make sure that you know, you're getting equal numbers when you have no MR, and then proceed to the actual cases that you have MR, right? So do your internal validation first before you start making decisions on your patients on continuity equation. This table is actually from the ASC guidelines on valvular regurgitation. This, I think, is a must-read paper for every cardiology fellow. A big table here, but if you wanted to focus somewhere, that would be the severe parameters. You need to know that before you take your ASC boards for sure, and probably for the ACC boards also. So mitral valve morphology is going to be significant pathology there in severe disease, such as flail leaflet, ruptured papillary muscle, retractions, perforation, tenting, poor leaflet coaptation. Your LA is going to be dilated, your caudal flow is going to be large, and it's going to be more than 50% of the LA, or you are going to have a centric holosystolic wall impinging jet. So that's a little bit tougher to evaluate how bad it is. Your flow conversion is going to be large and throughout systole. Your CW is going to be triangular, dense, and holosystolic. And then going to a little bit of quantidation, your vena contracta, as you know, you should be doing on parasternal long axis, measured in zoom view. And if it's more than 0.7, it's going to be severe. Pulmonary flow reversible, as I said, it should be more than one pulmonary veins. E-wave dominant is going to be more than 1.2 meters per second. Remember, a high velocity should mean actually either MR or MS, advanced diastolic dysfunction, or you have a prosthetic valve. So keep that differential in your head. And then going along to your quantitative parameters, an ERO of more than 0.4, a regurgitant volume of 60, or a regurgitant fraction of more than 50% denotes severe MR. And on the other side, you are mild. As you'll see, it's a normal leaflet morphology with normal LA and LV size. You're going to have a small jet, not visible flow conversion. And then your parameters is going to be an ERO less than 0.2, volume less than 30, and fraction less than 30%. All right. So know your numbers. That's something that you need to know actually. Now now that you diagnose your mitral regurgitation, how should you be following up this patient? This is actually very relevant for anyone that is practicing cardiology. So if you have mild MR, you should probably repeat an echo in 3 to 5 years. Probably it's going to be the same, but you want to make sure that that's the case. Moderate MR, you start becoming a little bit more careful, repeating every 1 to 2 years. And then if you have severe MR, of course, we're talking about asymptomatic, because if it's symptomatic, you should be doing surgery. You should be following them in an annual or semi-annual basis. Personally, I do every 6 months, to be honest. Obviously, you have to really focus not just on the MR severity when you are doing your follow-up, but also in your RV function and size, very important. You'll understand why later on. And your PA pressures, that's also very relevant. You'll see why. Now, some limitations, as I said, echo is very important, echo is great, but there is significant limitations. Of course, you have technical difficulties like obese and COPD patients, you're not going to have good images, right? Especially relevant to your quantidation. If you are having non-parallel Doppler alignment, it's going to lead to underestimation of the velocities and all the problems that you have down the road. Remember that you are doing a bunch of mathematical assumptions, like when you're doing your calculations, again, based on your quantidation. So there is the possibility of significant mistakes there. And finally, remember that the hemodynamic condition during the test affect the severity of the disease. The biggest one is hypertension. One thing that is very relevant for you guys, you do your TT and the MR looks more severe, and then like an hour later you do your T and the MR looks less. Well, the big thing is probably the sedation that you gave, which is actually, calming down the patient. The blood pressure is different. That's why you see all that difference, right? Now, why am I saying all those things? Because basically, don't hang your head just on a single measurement or a single view. Try to put multiple things together in order to be confident that you are calling basically a severe MR. And if you are not confident, then you should probably do some more testing. Now, what is the more testing that you can do? This is essentially the cardiac MRI. I think is the one of the most important, after echocardiography, is probably the second most important thing that you can do for your patient, especially if you are not sure about the quantidation of your mitral regurgitation. This is clearly stated on the recent guidelines for the regurgitant lesion evaluation, right? So what you do with CMR, you basically calculate the regurgitant volume as the difference between the LV stroke volume and the ascending aortic forward flow that you are basically calculating through phase contrast MRI. Alternatively, you can actually do a volumetrics between the difference of left and right ventricular stroke volume. Remember that things can get a little bit complicated if you're actually having also aortic regurgitation. Now, another very important role of the CMR, it can actually enables you to highly quantitate the size and the function of the LV, which is extremely important whenever you're trying to decide whether you need to do surgery. So remember, cardiac MRI actually has an important role in mitral regurgitation, especially if you are not confident with your echo. Moving along, stress tests may have like a minor role here. And the way that I usually use stress tests is if you have a patient with severe chronic MR, and based on his history, you are not getting a great history whether he is or he is not having symptoms, or you are, for whatever reason, suspecting that he's kind of downplaying his symptoms. What you do, you put them on the treadmill and you kind of prove to yourself and to the patient actually whether or not they are having symptoms. Another way that you can actually use the stress test is if you are having a patient with chronic MR that it doesn't look that bad, but the patient is giving you too much of symptoms. So you are trying to figure out whether what he's telling you and kind of put it into an actual number there. Cardiac catheterization. So again, a small role. The issue here is that you're not going to use it to diagnose mitral regurgitation or severity, but if you, especially in cases whenever you have a, classically you're going to have a patient that has a pulmonary problem also, and you are not sure that the symptoms that he's giving you, are they related more to their pulmonary disease or are they related more to their mitral regurgitation. So then you can do, of course, your right heart cath, you can get the filling pressures, and obviously if you have high filling pressures that are clearly suggesting a cardiac origin of their symptoms. So it can be useful in that situation, and we have used it a lot. Okay, now you have diagnosed your severe mitral regurgitation. How are you going to treat it? Like everything, there is the medical management, there is the surgical management that could be repair or replacement, and of course nowadays we have also the transcatheter mitral valve repair, right? So let's go one by one. Medical therapy. Well, that's easy. No non-medical therapy is alternating the natural history of severe MR, severe primary MR, all right? Very important. Now, you are going to give diuretics, and you are probably going to give afterload reduction also, trying to relieve the signs and the symptoms, right? But do remember that vasodilator therapy is not indicated if you have a normotensive patient. Even though it sounds like a good idea to decrease the afterloads to kind of create a path of least resistance going towards the aorta, it's actually not indicated in normotensive patients. By all means, if you have a hypertensive with severe MR, you should probably be choosing an afterload reduction as a primary agent. There is some data that suggests that beta blockers may have a role, but that's not firmly proven by any stretch. Now, if the medical management is not doing much, then what you should be doing is basically a surgical intervention, right? So yeah, that can get complicated also. And there is a lot of questions that you should be asking before you go ahead to your surgical intervention. You should be asking, when am I going to do the surgery? Why am I going to do the surgery, right? Where am I going to be doing the surgery? It's important. What type of surgery I'm going to be doing, how I'm going to fix the valve. Those are like relevant questions that you have to put your head together with your cardiothoracic surgeon and make a decision that is going to be best for your patient. All right. So this is an extremely important slide for your day-to-day practice, but for your boards also. All right. What are the indications for surgery? So class 1 indication. Don't miss any of those, right? If you have severe mitral regurgitation with symptoms, surgery, right? Second, if you have severe MR with LV dysfunction as indicated, either by an LVF of less than 60% or by an LVN systolic dimension of more than 40, so your LV is starting to dilate, that's also an indication for surgery. It's going to be a class 1 indication as long as your LVF is more than 30%. If your LVF has already dropped significantly, then it becomes actually, as you will see in the bottom here, it becomes a class 2 indication, all right? Now, class 2A indication is when you have, again, your severe MR and you have new onset of atrial fibrillation, or you have what they would call probably moderately elevated pulmonary artery systolic pressures of about 50 millimeters of mercury. And as I kind of briefly mentioned above, if you have your class 1 indication, but the LVF is below 30, then it's not that straightforward. But you know, if you're having a symptomatic patient with not much of comorbidities, you should probably consider doing surgery. Now, moving along, should you repair or should you replace the valve? That's again a very straightforward answer. If you can, you should repair. It has been proven that it's associated with better outcomes than replacement. Why is that the case? Well, there is quite a bit of explanation. First of all, the mitral valve apparatus is actually part of the LV function, right? It does aid in the LV contraction and maintains the efficient ellipsoid shape of the LV. So if you cut down your mitral valve, especially if you don't do chordal sparing, you are going to have problems with your LV function, right? Classically, your LV function kind of drops whenever you do surgery, by the way. Secondly, the repair is actually performed with lower mortality. So there you save some people just at the time of the surgery. And then finally, you are avoiding the inherent risk that comes with a prosthetic valve. If you're having a mechanical as you know, thromboembolism, Coumadin is a big problem. And then if you have a bioprosthetic valve, the functional deterioration is also a problem. So repair if you can, no question there. What is the surgical approach? I'm no surgeon, so I'm not going detail on that one, but some general things that you should know. What they basically do is they resect the flail and prolapsing leaflets. And remember that that's something that you might be asked of. You usually prefer to do reconstructive techniques using artificial cords. And that basically goes back to what I said before about the role of the mitral valve in the contractility of the LV. If there is significant alveolar dilatations, they usually, what they do, they put an annuloplasty ring. I'm sure that you've seen that a lot. Now, what you probably need to remember is that in an experienced center, the repair, if you in advance looking at the valve and it looks like that it should be a repairable valve, when the surgeon goes in, they should be able to repair it in 95% of the cases. That's not the case that if you are seeing that a completely distracted valve that in advance you knew that it's going to be a replacement, that should not be in that percentage, by the way, right? And then the other thing is that your operative mortality should be less than 1%. If that's not the case in your center, maybe you want to refer your patient in a more experienced center. Moving along to a little bit of a newer technique, the mitral clip, I'm sure that you all know about it, is basically the H2H repair. It's an H2H repair technique that is essentially reproducing the surgical alveoli technique. Get comfortable of seeing how that looks on echo, by the way. Even if you don't do it in your center, you are going to get some patients that got it in a different center, and you should be comfortable with how does it look a normal mitral clip. What do? You basically put a clip together in the free edges, usually in the middle A2 and P2. As you know, it's performed under general anesthesia, and basically the eyes of the interventional cardiology is basically the TE guidance of the during the test. Some complications that you should be aware of course, access site bleeding with any interventional procedure. And another one that you can sometimes see, and we have seen a couple of cases, is actually the partial clip detachment. Thankfully, I have never seen, and it's actually in the literature, it's very rare to see a complete clip detachment, which is going to leave from there and goes to the emboli somewhere. But partial lip, which is basically it gets detached from one of the two leaflets, and then obviously you're going to come back to any degree of mitral regurgitation that you started with. And you may need to put a second clip actually in those cases. Now, as you could imagine, when you are putting the clip, you are creating a little bit of stenosis, right? But as long as you did a careful assessment of your patient prior to going ahead with the mitral clip, and there was no significant stenosis before starting, then the development of clinical significant stenosis after a clip is quite rare actually. So this goes basically in your work that you did before doing it. If you did the appropriate patient, you should not have problem with stenosis, with significant stenosis, I would say. Also remember that once you put the clip in, the patients need to be either on anticoagulation if they have concomitant AFib, or DAPT for at least 6 months. So if you think that your patient is not a candidate for any of those, then maybe a clip is not a good option for them, right? Now, I think this is very relevant for you guys. I don't know if it's too early for the boards to ask, but definitely very relevant for your day-to-day practice. Who should you send for mitral clip? So you should send patients that they have moderate to severe MR or severe, of course. They should be severely symptomatic, at least class 3 symptoms. They should have a favorable anatomy, usually the A2P2 type of problem is usually the ones that you can more easily fix. They should have reasonable life expectancy, by the way. Usually 2 years is what we ask. As you know, for TAVR, we say 1 year. For CLIP, usually they say 2 years. But yeah, don't send your end stage, cancer patient for a mitral clip, of course, right? And then that's important actually to remember, they should have a prohibitive surgical risk. So your STS should be more than 8%. Why is that the case? Because in the Everest trial that basically compared the mitral clip to surgery, it actually showed that the primary outcome clearly favored surgery. This was specifically driven by repeat surgery for significant MR. So the bottom line is that if a patient is a candidate for surgery, you do surgery, you don't do mitral clip in primary MR. All right, remember that. Now, some treatment controversies in a primary MR. What should you do with your asymptomatic patients, which has severe primary MR with no significant LV dysfunction? As I mentioned before, that's not an indication for surgery, right? So you have two options here. If you are in a center of excellence that they do repairs with great results, then you can proceed with and it's going to be a class 2 indication of doing surgery. The idea is like kind of, I'm going ahead to treat this before I miss the boat and my patient develops irreversible LV damage. However, it is also reasonable to do what we call a watchful waiting, monitor your patients. I would say probably every 6 months, because this is what I do with a couple of patients that I have in this situation. One thing that I would say is it's tough to tell a patient that, you know what, you should go towards a major surgery like a open heart surgery if they're not having any symptoms. Remember that. Okay, moving along now to the secondary mitral regurgitation. As I said, a completely different entity than primary mitral regurgitation. So what is the problem with your secondary regurgitation? Well, it sure is not the mitral leaflets. That's primary MR, right? So as you can see again in our nice diagram here, it's usually a problem of the LV and includes two types. You can either have the ischemic type, which is usually the akinesis of the posterolateral wall, causing you that classic tethering of the posterior leaflet and the posterior indirect MR, or it could be your classic dilated cardiomyopathy, which is going to have tethering of both the anterior and posterior leaflet with your central jet. More recently, there is another entity that has been identified, is the atrial functional MR, which is in the case of severe atrial dilatation whenever you have long-standing AFib or severe diastolic dysfunction. I'm going to talk about that later on. What is the pathophysiology? A little bit different than your initial one. In this case, you actually start with the cavity dilatation, right? Remember on your primary, it was a secondary event. Here is a primary event, cavity dilatation. You have papillary muscle displacement. You have tethering of the leaflets and dilatation of the annulus. And then you start having your significant MR that is going to cause worsening volume overload. And then it's going to further increase the leaflet tethering and the loss of the leaflet coaptation. And then here goes again, and you're basically on that vicious cycle of worsening volume overload. Symptoms, again, they're similar like the symptoms of primary MR, but the subtle difference here is that the symptoms are actually present even before the mitral regurgitation. Why? Because you already had the LV dysfunction. So your patient already has the exertional dyspnea and the exercise intolerance, and then you put on top of that the mitral regurgitation, and it essentially makes the symptom worse. But they're already present even at the beginning of the disease in this case. How are you gonna diagnose that? Well, no surprises here. You are still gonna do your echocardiogram. Let's go one by one in those three different cases that I said, starting with the non-ischemic functional MR. You do your echo, you are gonna see a global systolic dysfunction, you are going to see a dilated LV, you are going to see tethering of both the posterior and the anterior leaflets, and classically you are going to see a central jet, right? And this is again a case of severe cardiomyopathy. As you can see, severe LV dysfunction. You can see that the leaflets look fine, right? They are nice and thin, but the problem here is that they are tethered, their motion is restricted. and you can actually see that there is malcomptation. They're kind of predicting in advance that something bad is going to happen when I put color. And of course, you put color, and yeah, severe MR, right? No question there. Let's go to something that is a little bit more difficult to identify. This is the ischemic mitral regurgitation. So what is the problem here? You basically have an akinetic or hypokinetic posterolateral segment of the LV. What happens is actually creates tethering of the posterior leaflet, right? And then what's going to happen, you are going to have a posteriorly directed jet. So how is that going to look? So let's pay a little bit more attention on this one. This is a little bit more subtle, especially for the first year fellows. So starting in this case, what is the problem? Well, let's look at our LV. So you see here that the posterolateral, that the basis is moving along well. Yeah, I agree with you. This is moving along well, but what happened is there is a problem right around here, right? So what's the situation from here and onwards? You see that this is akinetic, right? So don't get fooled by this part that is moving well. This part here is not moving at all. Then you see here, as it comes, it creates this tethering, and you look at the mobility of the posterior leaflet is significantly restricted, right? And then you have something else. Look at the anterior leaflet is just fine, right? And then you have what we call tip to body coaptation, right? When you see that, that's not good. That's a sign that there's something bad is going to come later on. So again, do the mental exercise in your mind before you put the color in. Think what you would expect, and if it comes right along, that means that you are on the right track. So here we are thinking that it's tethering of the posterior leaflet. We are going to accept that there is going to be posteriorly directed MR, and sure enough, you put the color here, and you see that a very eccentric jet, a wall impinging, it's holosystolic. Now, as you can imagine, the quantitation of this jet is much tougher. It's definitely significant. Now, is it moderate to severe? Is it severe? You need much more images. You need some quantitation techniques to say for sure, right? But it's definitely significant MR. And this is actually a beautiful freebie that I got from the literature, which is actually really showing what I was saying before, that tip to body coaptation. You see this is your anterior leaflet, which is moving perfect, and the tip of the anterior leaflet is actually going to the middle of the posterior leaflet, right? Instead of tip to tip coaptation, is tip to middle coaptation, clearly showing tethering the posterior leaflet. Moving along, this is kind of a newer entity that it's been nicely reviewed in the literature though, and it's specifically this atrial functional MR. It basically happens when you have significant atrial dilatation, such as in the case of chronic atrial fibrillation or advanced diastolic dysfunction. You know, restrictive cardiomyopathy would be a classic case. Typically in this atrial functional MR, the LV is perfectly fine, and your LV leaflets are also perfectly fine. So there is no other explanation, right? So what is the mechanism of this atrial functional MR? Well, this is actually, the most important thing is there is isolated annular dilatation, right? And then you have something called insufficient leaflet growth. You would think that the size of your leaflet remains the same throughout your adult life, but that's not the case. Actually, it has been proven by basic science that your leaflet can actually grow, especially if you are putting tethering onto the leaflet. But the problem is that some people grow more than other people. So if you have insufficient leaflet growth, then that's going to give you more atrial functional MR. Finally, some authors suggest that the impaired left atrial dynamics and some annular dynamics may have a role, but this has not been very well described or proven. And it's probably important to identify what type of, if you are actually having an atrial functional MR or secondary MR, because you may have different ways that you treat the two of them, right? I'm going to touch that a little bit later on. And for anyone that is interested to learn a little bit more about this secondary mitral regurgitation, I would suggest that it's a very nice JACC review paper from 2019. As you can see here is from Defrem et al. And it's actually very nicely and very elegantly describing this, this entity. Now, what I really want to kind of stress out to you guys is that the things that you need, if you want to remember like simple things, this is a patient that is going to have, you are diagnosing with moderate to severe MR, let's say, and you are not identifying an explanation. Why? Because you look at the leaflets and they look completely fine. There is no structural abnormality. There is no motion problem. Then you look at your LV, the LV function is perfectly normal. There is no sign of posterolateral akinesis or anything like that, right? And then when you have those things, you go move along and you see that there is severe LA dilatation, right? As I said, classically the AFib patients and the severe diastolic dysfunction. And, you know, conveniently enough, I was on service last week, and I did have this exact case yesterday, actually. Was one of our fellows, hopefully he's here listening to us. Derek, actually, we were discussing about that yesterday. All right, moving along, quantization of the secondary MR. This becomes a little bit more difficult, especially with those eccentric jets that I showed you before, that they need much more evaluation, right? And especially you definitely need some quantization, and PISA unfortunately can be misleading in these situations. You may consider MRI actually. Now, moving along, the other important thing is that for the same amount of mitral regurgitation, the adverse outcomes are more with the secondary MR compared to the primary MR. And so essentially, for a smaller calculated effective regurgitant orifice or less regurgitant volume, you are going to have worse outcomes, right? And considering that, the ACC and the AJ back in 2014 actually recommended to change the quantization. And they said that, you know what, you should be doing a regurgitant orifice of 0.2 and a regurgitant volume of 30 ml. As if that table was not enough for us to remember, then they changed it for the secondary MR, right? However, you don't need to know about that, because subsequently back in 2017, they came back and they changed it and they brought it back to the 0.4 and 60 ml as exactly it is for the for the primary MR. I have a reason that I'm mentioning you that one, because I'm going to explain you later on why there was this change. Now, how are you going to treat your secondary MR? Well, here it's completely different than the primary. You do medical therapy first. So you are going to do your ACE and ARBs, you are going to do your neprilysin inhibitors and transo, etc. You need to do your beta blockers, you need to do your aldosterone inhibitors, right? You also, before you even think of doing something for the valve, you should also do CRT if needed, of course, right? And then you should also revascularize the patient, right? As with the exact standard recommendations that you should be doing, right? Now, once you do all those things and you keep the patients a little bit of, and you give some time for those things to work, right? Classically, like 3 months at least, then you can start thinking for intervention if your patient basically continues to have significant symptoms. And remember that the evidence that this is going to prolong the life of your patient or is going to be significantly improving his symptoms are somewhat limited, with the exception of the COAP trial that you are going to talk about later on. So what type of interventions can you do? You can actually do repair or annuloplasty, basically. You can do a replacement, which is going to be chortal sparing. Remember that. I think that's a very testable question, actually. And you can do mitral clip, as you all know, right? Now, moving along, annuloplasty. So what is the rationale? Where you are basically overcorrecting the annular dilatation and trying to correct the MR, right? And, you know, obviously when you do it, it's going to have significant improvement in the mitral regurgitation. What is the problem, though, is that you're going to have, because the problem still remains there, when you're putting in an annulus and you fix the annulus, there's still the problem of the LV problems or the atrial problem. So what's going to happen is going to reoccur, and it's more than 30% of the cases that's going to happen. And it actually has not been proven to improve long-term survival or significant benefit on the symptoms. Now, do remember that in a case of, let's say, atrial flexion or MR, where the annulus is the main problem, maybe this patient have better outcomes. That has not been tested or proven, but that's a rationale based on the pathophysiology. Of course, this would be especially more important if you actually, let's say, this atrial fibrillation that you fix with whatever rhythm technique, and then you fix also the MR, then maybe these patients do better. Moving along, let's say that you decided to do surgery. Should you do repair or replacement? So you say, oh yeah, of course, we should be doing repair. Well, not so fast. Repair is great for the primary MR. Unfortunately, for the secondary MR, when they tested repair, when surgeons tested repair versus replacement, actually they showed that there is equivalent clinical outcomes. And why is that? Because you actually have much lower recurrence with the MR when you do replacement. Of course, you do have a little bit of higher mortality at the surgery if you do replacement, but if you put on the fact that you have lower recurrence with the replacement, that kind of equilibrate. And keep in mind there is no trial to compare the surgical mitral valve surgery to medical therapy alone for secondary MR. So, you know, based on all those things, essentially the guidelines give it a class 2B to do a mitral valve surgery in a secondary MR. Moving to something that has much more data with it is actually the mitral clip for secondary MR. As you guys know, there is quite a bit of controversy in this subject. Came out about 2 years ago, two important trials, the MITRA-FR trial and the QUAB trial. Very different results. The MITRA-FR basically enrolled 300 patients with moderate to severe, at least moderate to severe MR and an LVF of 50 to 40% and symptomatic heart failures. They monitored the patients for 1 year, and at the end of the 1 year, there was no significant difference in mortality or hospitalization. So basically a negative trial disappointment there, right? Soon after that, within a couple of weeks, here comes the QUAB trial, completely different results. So this was a 600 give or take patients, again, at least moderate to severe MR, LVF of 20 to 50%, class 2, 3, or 4 symptoms, despite medical therapy, right? And then they did the TMVR, and lo and behold, this significantly reduced mortality. We're talking about it 29% versus 46%. I mean, 29% is still a high mortality, but versus 46%, that's a huge difference, right? About 17% of absolute reduction. That's at 2 years, by the way, not 1 year, at 2 years. Also decreasing the hospitalizations. Within 2 years, you'll see a reduction from 35% to 68%. Huge difference, right? And you know, if you wanted to kind of really put it in your head, the number needed to treat to reduce one heart failure hospitalization at 2 years was three, and to decrease one death was actually 6 at 2 years. So quite impressive results, right? So the question right now is the following: Who should you believe? Should you believe the QUAB trial, or should you believe the mitral FR trial, right? Well, I would say that you should believe both of them, right? Why is that the case? Because they actually even though they tested the same disease, they included very different type of patients. And how is that the case? One is the grade of the amount of MR that the patient had. The EROA was the mean EROA in the MITRA-FR trial. It was 0.3 centimeters square compared to 0.4 in the QUAB. Why is that the case? Because I kind of mentioned that before. In the MITRA-FR trial, they actually used the old definition of for MR. So they were taking less degree of an MR in their trial, whereas in the QUAB trial, they were getting more degree of mitral regurgitation. Another important difference is what was the Elvin dynamics. So in the QUAB trial, in the MITRA-FR trial, the mean diastolic volume was 135, pretty huge LVs, right? Whereas in the QUAB trial was 101. And then and then the other thing is that the heart failure symptoms in the QUAB trial were less than the MITRA-FR patients. So what I'm trying, based on those two, the point is that the QUAB trial included patients with more mitral regurgitation and less LV dysfunction and heart failure symptoms. All right, that's the bottom line. And then I don't know if that was related, that had to do anything with the operators, or was it because of the indifference of the patients that they were using. But the success rate in the MR reduction was actually much more in the QUAB trial, 95% versus 83%. So putting all those things together, basically, you should identify the patient where the mitral regurgitation is basically disproportionately large to your LV dysfunction. That's the bottom line. So if you are thinking to do a mitral clip in one of your patients, you should identify the patients that they look more like the QUAB trial rather than the MITRA-FR trial. And you know, keep in mind that based on the MITRA-FR based on the co-op trial, the FDA actually approved the mitral clip for these patients. For the interest of time, this is exactly what you already described, so I'm not going to go into that. We already went through everything. It's exactly this diagram coming from the guidelines. So in summary, 1, primary and secondary MR are totally different entities in regards to pathophysiology, prognosis, and management. Primary MR is a consequence of it's an anatomical problem of the mitral leaflets or the subvalvular apparatus. If it's severe, you should treat, or if there is symptoms or signs of the LV dysfunction, you should be doing surgery. You should repair if possible over replacement. And mitral clip is an alternative if there is prohibited surgical risk. On the other hand, the secondary MR is mainly a disease of the LV. Optimal medical therapy is the mainstay of treatment, and consider intervention only if there is severe symptoms that are responsive to medical therapy. Remember to include your co-opt type of trial patients if you are considering that. Thank you for your attention. I'm happy to take any questions.
Thanks, George. I have a few questions here. The first one is, which echo view is good for looking at prolapse, both the TE and TTE?
So basically, this is the excellent question, actually. So basically the parasternal long axis is probably the best one to look. TT is ideal. In T is probably the 3 chamber is the one that kind of reproduce the parasternal long axis. But based on the guidelines, TT parasternal long axis.
What are the risk factors for post mitral valve commissurotomy, mitral regurgitation?
So, so you are talking about if you are doing
post balloon valvulotomy.
Yeah. So basically, the risk factor is actually everything included in your Wilkins scores, right? So whenever you have the heavily calcium, so you do your Wilkins scores, and as you know, in your Wilkins scores, what you are checking about the calcifications. You are looking about if there is actually, where is the calcium? Is it located on the tip? Actually, it's not included on the Wilkins, but you need to see where is the calcium. If it's located on the tip of the leaflets, or is it located on the more at the annulus. You should also look at the calcifications on the cords, and also very important, you should see the baseline degree of MR. So if you have more than anything that is approaching a moderate MR, you shouldn't be doing a balloon. So essentially, anything included on the Wilkins scores, and then also think of the area where is the calcification at the commissures.
Next is ischemic MR always due to posterolateral wall ischemia?
Yeah, the classic depiction of the ischemic MR is actually the posterolateral wall, basically on the dysfunction that you are seeing, as I showed on the echo there. Yep. Of course, if you have, let's say, an LAD, so, you know, if you have an LAD infarct that is causing basically a dilated cardiomyopathy because of, you know, 50% of the LV is down, then it's not going to be your classic ischemic MR though with the posteriorly dilated jet, right? It's going to be more of your central if that would be the case.
Yeah, the next question is, if annular dilatation is the mechanism of atrial functional MR, shouldn't that be type of a primary MR?
No, it's not type of a primary MR, right? Because usually the primary MR is like leaflet pathology, right? And here is clearly the pathology has nothing to do with the mitral valve apparatus. Is the dilatation of the primary event is the dilatation of the atrium that is subsequently causing dilatation of the annulus. So it's kind of like what came first type of thing.
Okay, I think I'll let Dr. Ashford take over to introduce our next